Excellent presentation. Thank you, Brad. And we are going to have a panel discussion after the break, and we're going to have many of our colleagues from Rush join our speakers, and we're going to actually have many of these questions answered again. So if you do have questions, please write them down, keep them in mind. Our next speaker, so we learned about low tumor burden, and I think it is so important that this is why you're here, to get knowledge. And the more knowledge you have about your disease, the better you may be treated during the course of your disease, because you can question your doctor as to why are you recommending that. So please learn about low tumor burden. Understand what high tumor burden is and what symptoms are. And there will be a time when you may develop symptoms and a higher tumor burden and require more than just rituximab monotherapy, and also many patients who have had perhaps maintenance rituximab therapy may become refractory to that. So you have to learn what that means. Refractory to a drug means that you either had no response to it at all, your lymph nodes are growing through that treatment, or that you had progressive disease within 6 months after receiving that drug. And so there's a whole group of patients down the road who will become rituximab refractory. And there are definite approaches to those patients, and there are actually drugs and other forms of therapy that have been approved for the patient who is rituximab refractory. Dr. Rummel is our next speaker. He comes to us from Germany. He's head of hematology. He is world famous and a friend, and has done probably most of the work with Bendamustine in Germany and brought that drug to the United States. Dr. Brad Cull treated 100 patients and led to the approval of Bendamustine in the United States for relapsed and refractory low-grade lymphoma. And so Dr. Rummel's going to talk about what to use when rituximab isn't working. And then he's also going to tell us about a very exciting trial that he performed in Germany, comparing some regimens using bendamustine and some older therapies. So Dr. Rummel, it's a pleasure to have you.
So thank you very much. It's a great honor and a pleasure for me to be here. When I was invited by the organizers, I immediately said, yes, I will come due to 3 reasons. First, it is about follicular lymphoma, and I'm treating patients with lymphoma in Germany since 20 years, and this is my focus. Second, it is Stephanie Gregory, a very well-acknowledged colleague. I know her for a very long time, and she wrote the invitation, and that was the second reason. And the third reason, of course, is that they are interested in also showing my results, and I really want to stand for my results in order to communicate it to doctors, to physicians, to nurses, in order to share knowledge, as it was already mentioned before. Before I start, I also want to say some comments on the talk of Brad Carl. I absolutely agree with everything. We have the same strategy in Germany, exactly the same discussion and the thoughts. And I just want to add something with these anecdotes. For example, in that particular situation that you are really on a low tumor burden and you get chemotherapy plus rituximab and you're doing so well. And Brad Carl has said and discussed, yes, but also a patient without it is doing well. And one of the most important results of that one trial, which was mentioned from Brad Carl with that observation against immediate chemotherapy, is when you look to the curve for the patients without chemotherapy at all, they go to treatment, as Brad Carl described, after 2 years. But some patients, and this is approximately 18%, are still without any chemotherapy after 15 years. So these patients would be absolutely overtreated. So if you have an anecdote with a patient, he is out of treatment and no treatment for 15 years, you cannot base your whole strategy on one case. And the same for a patient who is doing very well after chemo rituximab in that situation. So we need randomized trials with a large cohort of patients before we can understand something and before we can give a recommendation to the general population. So my talk today is treatment and management of high tumor burden, bulky or symptomatic follicular lymphoma. And the second issue is, what if chemotherapy or rituximab is not working? And so that is, of course, now a different challenge, because the question in that moment is already answered. The patient needs chemotherapy, so we were all through that considerations, if chemo or not, if watch and wait or rituximab or chemo plus rituximab. So when it comes to that decision, the next question arises, which is the best treatment? And as Brett mentioned, probably in some patients, different treatment is the best according to their life situation, circumstances, widespread of the disease, symptoms, comorbidities. But in general, we have to learn out of what we found in our clinical studies. So because I'm talking about here studies which have done in parts in Germany, I have to say that some of the therapies I'm going to introduce to you still are investigational, because they are not approved in the States for that particular indication. In particular, I'm talking about Bendamustine, which is not approved for first line. But due to the two studies in America, led by Jonathan Friedberg and in particular by Brett Carl, that Bendamustine is available in the States as a treatment for patients who are refractory to rituximab treatment. So that is my first talk. What is if chemo or rituximab is not working? We have two different terms which can be used in that direction. The one doctor is saying it's refractory, the patient, and the other one can say, no, you did not respond. So it's very critical to find the difference. Refractory, of course, means that you are refractory to probably all chemotherapy agents, and there is not too much patience in that situation. So usually it's the case you do not respond to the one chemo, maybe you do not respond to the second chemo, but maybe the third selection is giving you a response. But the other question is, what if rituximab does not give you a response? And then we say, if this happened within 6 months after the last rituximab treatment, then we call it, according to a general consensus, a rituximab refractory patients. So in that particular situation, there was an official registration trial, and this was done, as mentioned before, by Brett Carl in the States. It was a multi-center study around the country, and this was the compound Treanda, that is the trade name, and the chemical name for this is Bendamustine, and this was investigated as a single agent in patients who progressed during or within 6 months of any rituximab chemotherapy. So, what is Treanda? Treanda is the trade name of the Bendamustine, and I want to show you just some information what Bendamustine is. Is it something new? No. It is, of course, new in most parts of the world. On the other side, it is 50 years old, because it was developed behind the so-called Iron Curtain, which is the former East Bloc German country, East Germany. So in that part of the country, they developed the Bendamustine, and the reason for that was, of course, that they don't want to negotiate in these days at all with West Germany. We had our Cold War, unfortunately. We did not communicate to each other. It was strictly against the law, at least from east to west. So they produced their own chemotherapy, and they wanted to be better than West Germany. That was the rule of the Cold War. That is your enemy. You have to be better. So they had the goal to develop a chemotherapy which in the end should be better working than cyclophosphamide and less toxic than cyclophosphamide. Of course, a very good wish. Everybody wants to have something like this, which is better in the end as less toxic. And of course, it was a wish of the people in Jena, in East Germany, in the years 1960s when they developed it. So they found this Bendamustine. So one side of the coin is that they gave it to all patients with that diseases, all non-Hodgkin lymphoma, chronic lymphocytic leukemia, multiple myeloma, Hodgkin's disease, Also, some patients with breast and lung cancer were treated with a treatment. On the other side, they have not published it at all because they were not communicating with the international community. They did not use the English language. The only language they learned was Russian. So they just wrote some small publications in German language, only available in East Germany. That is the reason why the rest of the world had no idea that something like bendamustine is existing. After the reunification of Germany, it happens that the East German colleagues told us, you can use bendamustine in that disease. And of course, to be very honest, in the very first years, we all were very skeptical because what comes out of East Germany was not at all accepted from the West German people. This is what we thought, and of course, it was not politically correct to say so. So we didn't say it, we said, yes, okay, maybe we will use it. And in the end, after 10 years, yes, when the East German colleagues consequently told us, why not use bendamustine in that patient? Then it happened that we used it occasionally. So it was my person, when I started in the year 2000, the first study in a controlled way with a bendamustine. I right away combined it with rituximab, and this was just another clinical trial in Germany to try to optimize the treatment option for patient. It was not a registration trial. It was done without pharmaceutical companies. It was just the motivation of doctors sitting together and say why we should not compare it to the existing chemo if maybe it is as good or better, or maybe it is not as effective as the other treatments available. So we started that trial, and at the same time in the States, they heard about that Treanda. I presented it first at the meetings. People came to the poster. You know, we have that poster presentations in that large international meetings like ASH and ASCO, and you can have an oral presentation like here, or sometimes you give a poster presentation. And I was a young doctor, 10 or 12 years younger than today, and I was standing there first time in such an international meeting, and I was very proud from Germany going here, and so many people were standing around my poster. All asked the same question: how it comes that bendamustine is available in Germany and is not available in the States? That was clearly a very strange situation for all people. And I found that 50% of the people standing around my poster were doctors, and the other were from pharmaceutical companies. So one of the pharmaceutical companies really made it on the basis of that discussion of that poster of a young German doctor to have the license for North America, and that is how the American investigators like Red Carl and Jonathan Friedberg developed the bendamustine, and they did a study in the rituximab refractory patients. So these are the people, very old photo, black and white, 1960. This is a group of the pharmacists and the doctors in Jena who developed bendamustine. Just one more introduction, that is the chemical structure of bendamustine. And if you are an expert, or you will see it even if you are a lay, you see here that green group is present, and that is the cyclophosphamate partner characteristics. So it's present here in the bendamustine. So they did another cyclophosphamide. However, they included another piece of the chemical structure of the cladribine or fludarabine, the so-called purine analogs. You see that red ring here, it's also here. So just from the chemical structure, you have a feeling, oh, that is an interesting combination between two classes of products. So this was a trial. I have the slides from Jonathan Friedberg. He gave it to me to present it here. And this was one of the two slides which showed more or less the same results. So this was a study only with bendamustine without any rituximab in patients who relapsed, indolent, or transformed and are refractory to rituximab. So we would say as clinicians, oh, that is a patient group with a really more or less poorer prognosis when they are refractory to rituximab. What we should offer them. And this was a trial. It was bendamustine single agent. And we all were interested in the results. What can a single agent chemotherapy achieve if patients do not respond to rituximab? So here are the results. All patients had prior rituximab. And here you see they also had prior chemotherapy. One prior chemotherapy in 41, 2 different and 3 different in 34 or in 13% of the patients. So heavily pretreated patient population. And the response rate was quite impressive. I was surprised from Germany when I read these results. 76% of the patients responded to just bendamustine without any rituximab when they are refractory to the last treatments. That is very surprising and impressive. Also, they have done a sub-analysis, and here it is. It is also to look for the patients who are not only refractory to rituximab, but also in addition refractory to rituximab plus chemotherapy. So that is the group chemo plus rituximab is not working together. What is the best treatment? And here bendamustine was sub-analyzed, and this, you see the response rate in that patient group is 60%. So they concluded, and I agree absolutely, bendamustine as a single agent show a high response rate in this pre-treated patient population who are rituximab refractory and also refractory to other alkylator chemotherapies, which is typically something like cyclophosphamide or the CHOP regimen. So that is why bendamustine is available and approved in the States. This is the official wording for bendamustine, and as mentioned before, the trade name for that is Treanda. So what you do when the patient is not rituximab refractory, but on the next slide, as continuing the story from Brett Carl, if you are not treated at all, you are previously untreated and first diagnosed, and after a somewhat short or long duration of watch and wait, or sometimes immediately, the doctor decides together with you, we need chemotherapy plus rituximab. So I want to address that question now. What is the best treatment? Do we have any randomized trials who compare the one against the other treatment so that we can give a good recommendation to our patients? So I want to address that question. So this was investigated. What was at least the most often used treatment in the last decade in the States? And here you see the doctors in the United States, and this trial was published in the year 2009. The doctors asked retrospectively what was the most often used treatment in your institution. So 55% of American doctors administered CHOP plus rituximab. That is a polychemotherapy consisting of 4 different medications. 23 used the less aggressive one, which is CVP, very comparable, but 1 compound is missing. And 15% were using something different, which is called fludarabine based plus rituximab. So that is the situation. There is no general consensus what is the best, and therefore the field is open for more randomized trials. I want to show you what was done in the last years. So one group from the States, and I'm very thankful to Oliver Press who gave me that slide. He presented it. They done a randomized trial of the more or less most often used regimen, which is CHOP plus rituximab, and the other group of the patient got CHOP plus radioimmunotherapy, which is a radioactive immunoconjugated rituximab antibody. So very interesting trial. The whole community knows that trial was ongoing for the last 10 years. Everybody wanted to see the results. And these are the results. So it is like this. The progression-free survival was presented at that meeting, and the curve with the CHOP plus radioimmunotherapy was here above the CHOP, and this was a little bit better than the CHOP plus rituximab. However, we say as statisticians and as scientists, The difference maybe is there by chance because it was not statistically significant different. So that is progression-free survival. Everybody wants to see the overall survival probability. And again, the curves looks very comparable, but now it's the other way around. Also again, no statistically significant difference. Two curves looking very much, but now the radioimmunotherapy is a little bit inferior to CHOP plus rituximab. So in the end, as Brett Carl mentioned, you can look to these results a long time and you are discussing with your colleagues what is the best interpretation out of this. You can say both treatment strategies are quite good and comparable, and there is of course a difference if you give 6 times rituximab or 1 time radioimmunotherapy. So you cannot make a clear recommendation out of that trial. Another very interesting study was done, and again, I told you in the States is given CVP or CHOP or fludarabine, both with rituximab. So this is a trial from Italy, and they compared it exactly what I said, all the 3 regimens together. What is the best when you do it randomly assigned to 1/3 of the patients to the one, 1/3 to the other, and 1/3 to the third treatment. So that is what they found out. So the CVP is a little bit inferior, and CHOP plus rituximab is more or less the same in terms, again, of disease control. So the question is, what is the standard? Is rituximab CHOP still the standard? Yes, at least. It is in the best curve here, and the rituximab fludarabine is quite toxic. That was another conclusion. It was very effective, but quite toxic. So the Italian doctors still believe rituximab plus CHOP is the most often and best treatment. That is the moment why there is good reason to again challenge that so-called standard treatment CHOP. So in Germany, we investigated that treatment, and we initiated that trial in the year 2003 in a large German cooperative study group. Bendamustine rituximab against CHOP plus rituximab. Just to say again, this is a disclosure, very importantly. This drug combination is not approved from the FDA for the frontline setting. It is investigational, and we have presented that trial and the results at many meetings, so they are very open and public available. So this is what we've done again. I want to show you. We used just one single agent, bendamustine, in combination with rituximab against a polychemotherapy with these different chemotherapies. So when you have 4, everybody can assume probably there is more side effects possible related to a 4 regimen compared to a single. On the other side, many colleagues, when I was doing that study 10 years ago, called me on the phone. Just imagine I was a young German doctor, not very well known, and suddenly my phone is ringing all the day, all from the very well-known professors, and they're telling me, what are you doing? You cannot compare one single agent to that very established standard. You're going to put your patient at risk. It's unethical. So I was discussing it with my colleagues, with my ethics committee. Yes, we should do this trial. Nobody knows if this is really inferior, but we expect that the toxicity is by far less. So the German authority, like the FDA, it's called BfArM, the German ethics committees all said, yes, do that trial. And in the end, I was feeling, when so many people call me on the phone, probably it is the right study to do. Yes, that is what I was feeling, and in the end, I show you the results now. It is good that we have done the study. As Brett Carl mentioned, indolent lymphomas not only include follicular, and we adopted that. We included that Waldenström's disease, that marginal zone, which was mentioned by Brett Carl, and the small lymphocytic. What is a special part of our study, that we also included some elderly patients with mantle cell lymphomas who are not eligible for a more aggressive treatment. So this result, that is the official slide, was presented to the world community of scientists just in May also in Chicago. So this was a trial. All our patients, as already showed you by Brad Carl with the GELF criteria, we used very similar, not exactly GELF, but very similar. All patients are in need of treatment per these defined indications: symptoms, hematopoietic failure, large tumor burden, rapid progression, or complication due to the disease. We included 514 patients, much more than expected, because the motivation in Germany to include patients in such a trial is very high. And of course, the German doctors, they are very convinced to investigate the so-called German compound. So they randomized their patients, 514, and the vast majority of the patients had follicular lymphoma. This is the patient characteristics. As Brad Carl mentioned, we need that information to compare it to other trials. So you see here the FLIPI factors which have been introduced to you. And of course, the most important thing is to see in both treatment arms, patient group is very similar. We're reflected by the age, 64 years here, 63 years here, some bone marrow infiltration in the same range, some elevated LDH, so it gives you a good feeling. The two groups of patients are very comparable. So first, we show the toxicity on all these meetings, showing that the side effects to the blood, having some cytopenia after chemotherapy, was seen less often after bendamustine rituximab. This is a cytopenia, a very severe one. We call it grade 3 and 4. This was by far less often seen in the bendamustine-treated patient group. Only 12% of all treatment cycles had this cytopenia, compared to 38% of the CHOP-treated group. On the other side of the coin, this growth factor avoiding that side effect is GCSF or Neupogen. So that's a growth factor for the white blood cells, a very costly product, high price for that. And you see in 20% of the treatment cycles after CHOP it was used, and only in 4% after bendamustine. So from the non-hematological side effect, this is a difference. You have immediately, you can see alopecia, hair loss is a big difference. No patient with bendamustine is going to have any hair loss, while every patient more or less has some degree of hair loss when you treat him with CHOP plus rituximab. That is, of course, in my opinion, and my patients are going to tell me that every time, a very important difference. Even if you know that your hair is coming back, patients coming to me 2 years in response, they tell me the worst thing about that 6 months of treatment 2 years ago was that I had hair loss. I believe it, yes, so that is a very important difference. Also, the patient with CHOP rituximab had a little bit more neurotoxicity, more stomatitis, a little bit more infections, and we have seen more skin reactions as a side effect of the medications in the bendamustine treated group. So these are the response rate here, and this is a very good result for me as a young doctor in these days. I was very happy to see no, patients were not at risk. At least the response rates are the same. 92% responded to that treatment compared to 91%. That is exactly the same. So we were very happy. In the short-term result of the treatment, it is the same. But this is not the most important in patients with that disease, because achieving a response is more or less easy with a combination of rituximab plus chemotherapy. What is reflected here? 90% of patients respond. It does not matter which treatment you are on. However, what is the long-term effect of that treatment? How long your disease is not coming back? How long you are chemotherapy-free for the next treatment? How long is the response lasting? And that was the primary goal of that treatment. And these are the results. And this was a surprise, because it surprised nearly everybody that not CHOP plus rituximab is better, but bendamustine plus rituximab was superior to the CHOP plus rituximab curve. So that means in the end, that the old developers in Jena 50 years ago, when they wanted to start their fight against the West German pharmaceutical companies to produce something which is more effective and less toxic, we see it here 50 years later that they probably had the right plan to develop bendamustine. So bendamustine had a median progression-free survival, and that is again a statistical calculation. As Brad Carl has explained it to you, 50% of patients still have no progression of disease after 70 months, compared to CHOP, in which after 31 months, patients had already a progression in the median. But this is for the total patient group, which is a little bit the weak part of that curve because it includes all different histologies. But also, I have shown here the results for the follicular lymphoma patients also. And here again, you see that bendamustine rituximab was clearly superior to the CHOP rituximab curve. And now the median progression-free is 41 months after CHOP-R. And we have not achieved the median, that is 50% with the bendamustine rituximab. So that is all the 4 entities. Just to show you, Stephanie has mentioned, we have also treated patients with some other lymphomas like Waldenström's, and marginal zone was included. And this is the sub-results. Always you see that the bendamustine rituximab, the yellow curve, appeared to be superior to the CHOP plus rituximab curve. So does it matter if you have a complete response? And that is, of course, a complicated issue because, as Brad Carl told us, that is not the same as to be cured. But when you have a complete response, that means that with no diagnostic procedure, you see something of your disease. The lymph node size is normal, bone marrow infiltration is not present, you're feeling absolutely well. And so does that mean something for your outcome? Yes, it does. The patient who achieves a complete response in that trial did better in regard of progression-free survival. And also, interestingly, and maybe as expected, the survival probability was better. The patient with complete responses had a longer survival probability than the patients who achieved only a partial response. That means that you could still see some lymphoma residual disease when you do your diagnostics after treatment. So this was adopted by the NCCN guidelines. This is a national cancer, comprehensive cancer network. And I was very surprised that after my presentations in these countries here for the international scientific meetings, that the National Network for Comprehensive Cancer adapted that treatment recommendation in that slide. So it was a big moment in Germany that this was shown to the German doctors because not too many Germans look into that homepage, website of the NCCN guidelines. But then it was a rumor in Germany. Look to the NCCN guidelines. The bendamustine rituximab is recommended there. How comes our trial made it to the world? Interestingly. Yes, it made it to the world. So when you go to some other countries of the world, and I will show you soon, bendamustine is now available in most countries of the world. And you have seen that there are good reasons for that. So the NCCN guidelines recommends bendamustine rituximab as frontline treatment. And all German doctors made the following interpretation. Oh, look here. It's the very first recommendation. Again, over our CHOP. But this is not true. That is not meant by it. They say in that small letters here, this is in alphabetical order. To be very honest, when I saw that slide, only my eyes were focused here, and I have not read it. And this happens to every doctor. I mean, if you are an expert looking to that NCCN guidelines, you know it, because they do it for all diseases. But when you're just looking occasionally, you are absolutely misled, and you say, oh, I have to use this because this is the best. And that is not true. It is only some results I have showed you, which is suggesting, yes, indeed, bendamustine rituximab is a very effective treatment option. So this is how that old drug made it to the world, and I just want to show it because from my view, that's a fascinating story. 1963 it was developed. 1992, a small company which nobody knows had it after the reunification, but I told you nobody in Germany was using it, exception the East German doctors. Then there was a small company in North America who had the license for developing 2002, and then it's available now in Japan countries from that company Symbio, in all European countries from that company. Then there is some availability in Russia, Middle East, North Africa, in Latin America, in all South Asian countries like Indonesia, Malaysia, in Australia, and of course in the States, in China, and just recently in Canada. A very interesting story. After 50 years, it is now available in the world, a very old German compound. And this is all the names available in the world. Interestingly, it's not so easy like just saying rituximab, because Rituxan and rituximab is very similar. So the trade name is different. We have that Treanda in America, Livact in Germany and Europe. Bendamustine is a very old name. In Japan, it's called Treakisym, and in Singapore, it's called Symbenda, and probably there are some more names around the world, but more or less all doctors know it only under the name Bendamustine. We know all that after the induction, like Bendamustine rituximab or CHOP rituximab, probably you have to expect that the disease is coming back, and maybe and hopefully some of the patients are on a very long-lasting response. But they will try to improve treatment in order to give something in addition after the chemotherapy plus rituximab, that is consolidation or maintenance treatment. So that was a one trial which was done by the French study group, and they again used that 3 different chemotherapies and then randomized rituximab maintenance or just observation. And that was shown here and found by that study group. They showed that rituximab maintenance was superior to just watch and wait the patients after they have been successfully treated with a rituximab chemotherapy combination. And this is only in terms of progression-free survival. And the last speaker, Brad, already showed you that this is an ambivalent situation, because just progression-free survival, as we show it in most studies, and as I have shown you with the Bendamustine rituximab against CHOP rituximab, is the one side of the coin, but we do not know yet if this is really translating into a really improved overall survival. So this is how we are doing it now in Germany. We adopted that 2 years maintenance, and therefore we initiated that trial, and this is just to show you the perspective of the future. This is what the Germans have done. We have randomized Bendamustine rituximab as a backbone for both treatment arms, and the one group is getting 2 years rituximab maintenance, the other arm is getting 4 years rituximab maintenance. Very interesting question, and I'm absolutely open and eager to see the results, which we probably only can report in more than 5 years from now. And that is the other trial for the non-follicular Waldenström marginal zone. We randomized Bendamustine plus watch and wait against Bendamustine rituximab and 2 years. So in the end, I say, as Brett Carl mentioned, I think there is still a role for watch and wait for certain patients. If it comes to treatment, combination of rituximab plus chemotherapy is standard. The Bendamustine plus rituximab can be a preferred treatment option, at least according to my opinion. The rituximab maintenance as consolidation of achieved responses can be given. The high-dose treatment, which was not discussed, which is autologous stem cell transplantation, only in my opinion, is good for some patients with early relapses. But there are still more things ongoing in the future. We have many new compounds, bortezomib, ofatumumab, lenalidomide, GA101, ibrutinib, KL101, and I pointed them out in yellow because these are all under investigations, and the yellow one appears for me the very promising one. To show it in 2 slides, what is the future for the lymphoma treatment field? That is one slide, very confusing. These are all the new agents on the horizon under investigations. Better you don't read it and you don't understand every word, but these are all new investigational agents. To summarize that slide in a more better and optical view, I created that slide. What you would ask the machine for it, it's just the compounds under investigations for non-Hodgkin lymphoma. Yes, there are very many, and that is a good hope for all of us. Thank you for your attention.
Definition of low tumor burden, what we should do for that, higher tumor burden. We have a break coming up. Time for one question, and then we're going to have a panel discussion. All of our doctors and our colleagues from Rush will be up on the podium, and you can ask these questions for another half hour. One question.
Okay, thank you. I just wanted to say thank you to Dr. Rummel and Dr. Gregory for all you do for everybody, because it's awesome. So I think they deserve a round of applause for what they do every day.
I send that to all of our doctors.
Well, in all of them, yes. But Dr. Gregory, you know, you're our doctor, so of course I have to. But I have to admit, I mean, Dr. Rummel was one of the key reasons why we came today. So thank you for coming from so far.
It's an honor for me to hear that. Thank you very much.
Yeah. So I really appreciate everything that you do. One question I have, though, is that you said that bendamustine rituximab is not approved as a first-line treatment, but it was offered to us as a first-line treatment, not just by Dr. Gregory, but by another oncologist. So I was a little bit confused about that.
So, to be honest, I was told by some people in America to always say that it's not approved. Probably, as you can imagine, the people who tells me that are lawyers. So in Germany, I would not say it like this, because we as clinicians and as scientists only believe in data, and we only treat our patients according to evidence and data. And in Germany, at least, it's not according to the label. Because the label sometimes is 10 years behind, and it's not moving so fast as we have seen new agents. So in Germany, when you do something which is effective, and in some cases you don't do it, you do something wrong. So in Germany, it does not protect you if it's in or off-label. If a patient goes to you and you recommend only in-label treatment, and on the other side, it is well known that another treatment is available, you have to give it. And the reimbursement issue is a little bit different in Germany than in America. So that is the reason why I always present data, and I cannot say how it is being dealt in all countries. So maybe I don't know, and of course you believe that I don't know. Ever maybe it's available for first-line treatment in your country or not. The problem is that my trial definitely was never planned as a registration trial, and therefore it is very logical that the American authorities will have a lot of problems just for formal reasons to accept such a study, which we call in our terms IIT investigator-initiated trials, that usually is not accepted by the FDA for a later approval. Very clear. That's the rule, and so I don't know.
So in answer to your question, if you have evidence that there is published data, or if you can go to the National Comprehensive Cancer Guidelines, the NCCN guidelines, and these combinations are listed as available for first line as a recommendation, or that you can show published articles, insurance companies will often pay for it when it's used frontline. So that's how in the United States we are able to use some of these agents that by label are only indicated in the relapse refractory setting. There is data that insurance companies will look at to pay for those drugs. One of the issues is if it's not approved, will insurance companies pay for it?
Okay. Thank you.